Hello everyone, how are you guys doing? Today, I'd like to talk to you about status epilepticus. It's one of the interesting topics I'd like to talk about. I think it's very important for all residents to know. I think it's one of those cases where you 100% will interact with on multiple occasions, and you're going to be the first line of leadership during that rapid response wherever your residency is until backup comes. So you will probably need to be very much prepared to go through all of those algorithms, understanding of seizures. So this lecture is going to be not talking about seizures overall in general. I would like it to be more focused on the prominent things and to build a baseline for understanding of seizures. I'd like it to be more of a basic knowledge for seizures and status epilepticus. We can in the future work on episodes where it talks in depth about seizures, but for now I'm just going to touch base on how to form in your brain an algorithm and a differential on the go as you are working. It will be very interesting, and I hope you guys benefit from it. So basically, let's start. Let's do this. I am 100% not tech savvy, but I hope this helps. Okay, so first things first. How would you, in general, classify seizures? So we're not here talking about status epilepticus just yet. We can classify seizures as multiple ways, and there's multiple definitions or classifications for it. There are the ones I like to kind of work with in general, but you can base it based on multiple things. So let's go and do it this way, for example. So we can base it on whether it is a febrile seizure or a non-febrile seizure. We can differentiate it as a primary seizure or a secondary seizure. Or at times you can differentiate it based on how it presents. So you can say, oh, this is a focal seizure. This is a generalized seizure. Or this is an absent seizure. Okay? So, how I like to differentiate it in a way which is easier to do in pediatrics is going to be more of febrile seizures and non-febrile seizures. And then non-febrile seizures can be primary or secondary. Okay, and regardless, they can present however. One of the interesting things before we move on from the previous classifications is when we talk about the generalized seizure, the focal seizures, the absent seizures, which one would strike you more as emergent? Usually when I ask that question to my students or my residents, they will always say generalized seizures is more concerning. And it is more concerning because it's the length of the seizure equals brain. So time is brain in status epilepticus. However, when you have a focal seizure, it's point to an area in the brain that has a defect. So it's actually more concerning to have a focal seizure. Think of space-occupying lesions. Think of tumors. Think of hemorrhages. Think of abscesses. Think of a spot in the brain causing that seizure that might need surgical intervention, basically. Okay, and then you can always differentiate them to myoclonic seizure, tonic-clonic seizure, and the rest of it. So febrile and non-febrile seizures. So febrile seizures are usually differentiated into simple febrile seizure or complex febrile seizures. And complex febrile seizures will be then differentiated to, are these complex febrile seizures have concerning features Oh, do they have non-concerning features? Okay. So circling back to all of that. So before we talk about febrile and non-febrile seizures, this is us building an algorithm in your brain, thinking about it in a simple way. When you're in a seizure episode and you're following the algorithm for treating status epilepticus, at the same time, when you get to see it over and over again, you're working through these differentials in your brain on this step. It just needs to be seen over and over again. It doesn't happen overnight. You need to build that differential in the back of your brain, so when you ever see that happen, you can run through differential, and you will see us tackling each of those differential by things that we do in status epilepticus algorithm. So primary seizure is basically epilepsy, something that is happening centrally from the brain. It's whether it's genetic in origin or idiopathic in origin, is epilepsy. Causes of secondary seizures can be multiple. So what causes of secondary seizures can we think of? We can think of infections, right? And infections will fall under that febrile seizure part. However, febrile seizures, when we talk about its differentials, it will see about the concerning and non-concerning features, which we will discuss. But these infections I'm talking about mainly encephalitis or meningitis or brain parenchymal abscess. So, one, it can be infection. If not infection, what can it be? It can be space-occupying lesion. Think of hematomas. Think of trauma. Think of tumors, right? 3, metabolic. Think of your inborn error of metabolism. Think of electrolytes. What would be the electrolytes more concerning for affecting the brain? So, sodium, glucose, to a lesser extent, magnesium. So, potassium will affect mainly your muscles and heart. Calcium will affect mainly your muscles, but that does not deny the fact that to an extent it can still affect your brain. So it goes on your differential for electrolytes imbalance as you go onto it. Okay. Metabolic also technically, as you look for your inborn error of metabolism or genetic diseases or organic acidemias. 4, you have drugs, toxins. Most overdose or toxins won't cause seizures. Even valproic acid won't cause seizures because of that sodium channel affection that it has. So always consider toxins and drugs iatrogenic or overdose or accidental in your differentials when you order things or when you deal with the patients in seizures. So you have infections, you have space-occupying lesions, you have metabolic, you have drugs and toxins. What else can cause seizures in these patients? Also think of cardiac causes for seizures. And people don't usually think of cardiac causes when they're looking at seizures because it's low in the differential. However, you need to understand that arrhythmias can cause seizures. It should be low on your differential, but it should be there on your differential. And then, of course, anatomical structural defects that can cause seizures. Okay, so when we are talking about febrile seizures that we're discussing, we said, febrile seizures can be simple or it can be complex. Parents will have a kid with febrile seizures. They will be very concerned, and it is tremendously shocking when you see your child having a seizure. You need to be able to get from that history, whether it's a simple febrile seizures or a complex febrile seizures, because it will determine whether or not you will observe them in the emergency room, you'll admit the patients to the floor, and your further interventions that you will do. So that being said, before we define this, we have to define what is status epilepticus. There's a very old definition that was saying, it's about more than 30 minutes, that is status epilepticus. That is no more the base, and it's basically status epilepticus is defined as this is a seizure or seizure activity lasting for more than 5 minutes. Lasting more than 5 minutes, and this number will be important when we go through the algorithm, having at times recurrency or having recurrency without going back to baseline, or increase, and it has to be more than 2 months of age. So this is a patient that is more than 2 months of age. At times, some definitions will exclude it. Some definitions will include the age limitation because of neonatal seizures. And you'll have this patient is having either more than 5 minutes of seizures, persistent seizures, or having recurrent seizures without going back to baseline. So, what would be simple febrile seizures? So, simple febrile seizures is basically a seizure that lasted.
May I have your attention, please?
Sorry about that. There was an announcement at the hospital. So, simple febrile seizures is basically a seizure that is lasting less than 15 minutes. There's no focal features. It's a single seizure in 24 hours. Does not require abortive medications. And the patient was able to return back to baseline. So, what about complex seizures? So, complex febrile seizures, whether they will be with concerning features or doesn't have concerning features, is going to be based on this. So this is a concerning features is a seizure that is last more than 5 minutes. This is a seizure that has more than one episode. Sorry, where did it go? There. So this is a seizure that is lasting concerning features. This is a seizure is lasting more than 15 minutes. Let's actually do it in a much cleaner room. Okay. So I'll have it this way. So this is concerning features will be basically this way. 1, this will be a seizure more than 15 minutes, or more than 5 minutes with treatments, requiring abortive treatment. This has a focal features or has Todd's paralysis. This is a seizure that occurred more than 3 times within 24 hours duration. And 4, this is a patient that has failure to return back to baseline. So it would be a complex seizure without concerning features. It will be less than 50 minutes. There's no focal features. It's about 2 to 3 seizures within 24 hours. There's not treatment that are required to be stopped. Return to neurological baseline. Some of the things that you need to understand as a concerning feature prior to discharging the patient home from the emergency room includes some things that are not symptoms based. So basically, you want to make sure that this patient has one, good anticipated follow-up with their PCP, or if you're recommending neurology. Even though febrile seizures should not be referred to neurology except in certain criteria, but in general, you want to make sure there is anticipated follow-up with their pediatrician. One of the concerning features as well is if that patient is less than 2 years of age, you need to really make sure before you're sending them home there is nothing more to investigate if that is a straightforward, simple febrile seizure. Okay? Okay. So this is a simple classification, as I said. Basically, you're thinking of differentials as you go and you bolt out. So now what happens is you are on call and the nurse calls you, this patient is seizing. Things to think of, first of all. One, time. Make sure she has how long has that patient been seizing, or when did it start, because it's going to determine when you're going to give mitigations and how you're going to deal with interventions as you go further. Two, until you arrive to that room, make sure she has that patient in a secure position. Make sure they have the supplies that you need at bedside, which we will discuss. So how I like to think of management, and I'm telling this in a more systemic way, but the more you do it and the more you see such cases, you'll understand that it's a more of a dynamic procedures or dynamic steps. So everything is happening at the same time. I like the approach of A, B, C, D in all emergencies, at least initially, as you are thinking of things to do. Okay, until you know that everything is done, everything is secure. Okay, so airway. One, you want to make sure that the airway is patent, clear, and secure. You do not put anything in the patient mouth. Okay? One, you can also put the patient in recovery position if need be until you have a more secure airway. Okay? That being said, you go for breathing. So, in breathing, you want to give the patient, take something from the patient and give something to the patient. I like to always put that in this perspective. You want to make sure you have your monitor on, so you're looking at your SpO2 and you're giving the patient an oxygen modality, right? So either you give the patient a non-rebreather or a Venturi mask. And you can use, usually we say non-rebreather mask. And the reason why we say non-rebreather mask, it's one of the high flow modalities. You crank it up, so when you are a resident, you're an MD right now, so you need to stay strict and very understandable orders. So when you tell the nurse, I need, or the RT, you need to put something, you need to be aware that you're telling her, I need this patient on a non-rebreather mask of 15 liters, or crank it up as high as you can. Be very specific with your orders. You can't just say, I put them on oxygen. They put them on nasal cannula, they can put them on a simple mask. You need a non-rebreather. And the reason why we usually want such modalities, or especially non-rebreather, because it helps with apneic oxygenation. And this is a side note of apneic oxygenation. Some people will be aware of it when they're intubating a patient and they put a nasal cannula in that helps with apneic oxygenation. But basically, what it helps with in apneic oxygenation is you're giving that stacking of oxygen in here to overcome the dead space, and you're using it to flush out the CO2, but you're also using the heart the heart palpitations, or the cardiac contractions, to be used as an oscillatory effect, which is very minimal, to help diffuse that oxygen. Okay, so basically what you do with the non-rebreather mask is apneic oxygenation in such patients. Okay, and then cardiac. So you look at the patient's heart rate, look at the patient's blood pressure, and you look at the patient's rhythm strip. So you hook the patient on a monitor. Okay, and the reason why I want you to look at this during a seizure, because you want to make sure that your patient is not having the Cushing triad. And your Cushing triad will be that patient having bradycardia, patient will have hypertension, and will have cosmo or irregular shallow breathing. And that is a sign of brain coning or herniation. And it can happen during status epilepticus, especially if prolonged. So your eye needs to be on your vital signs. Expectedly, seizures are a very stressful event on the body. So you anticipated the patient's heart rate will be up and the blood pressure should be up. You're looking at the strip because remember, we mentioned that arrhythmias can occur causing that, okay? And then cardiac, you want to get an IV access. Getting an IV access in general is important, but I don't want you to fixate on getting an IV access. Remember, all of this is occurring on the clock. So you have a time span, which we will discuss later on. All of this should be occurring within the first 5 minutes because you're on the clock. If you are not able to establish an IV access, make sure to be aware that you can use an intranasal, you can be used a rectal, or you can use intramuscular. So you have other things in your arsenal to use until someone experienced can come get an IV in status epilepticus. Then D, disability. You cannot assess Glasgow Coma Scale in status epilepticus, but you can assess the pupils. You want to make sure the pupils are bilateral equal and reactive, or at least bilateral equal, because a dilated unilateral pupil can point to something happening in the brain, which will tell you again, feed you in that increased intracranial pressure effect that you might have, causing that herniation. It's a different story, a different beast, a different modality that you need to check. Now that you're looking at this, I want you at this point look for your glucose. So you can order always an I-stat BMP, which will show you electrolytes imbalance and will show you glucose. Hypoglycemia is a common cause of seizures, easily reversible, and also time is brain with it. Okay? If you neglect to notice hypoglycemia, it will cause serious damage. You're expecting in a seizure mainly to have hyperglycemia from the stress. At times it can be burnt hypoglycemia, but if there's a serious or critical hypoglycemia in a setting of status epilepticus, you're treating it. And then you get your BMP for the electrolytes that we discussed. Okay, why are we not getting blood gas? Well, you can get blood gas, which is fine. However, if you're getting a blood gas, you need to understand that having a status epilepticus will have that metabolic acidosis, will have that increase in lactic acid. There is an expected rise. You can get it to see the severity. However, blood gas is not usually an indication during a status epilepticus. Maybe afterwards you can get it, or if you have a baseline before the seizure happened, would be more realistic about what's happening in that patient. And then E is exposure. So you'll get that patient temperature and you'll check for trauma, signs of trauma on the patients. But you can also check for toxins. Toxins will come afterwards, so we'll check it in the UDS after the patient is stable. It's not an emergency at this moment, unless you're thinking it's a seizure secondary to a toxins overdose and you have that valid history and you want to give them a antagonist or an antidote to help as well. But you'll see that the treatment of seizures itself as an algorithm goes ahead independent from the cause. So let's say this is a febrile seizures and it's a complex febrile seizures and the patient is continued to seize. When you are doing temperature control measures, antipyretics, you'll either give them rectally, you'll give them intravenous acetaminophen, you'll cool down the room temperature, but you need to be aware if you're doing cooling measures in a patient who's having status epilepticus, make sure you're not causing shivering or making that muscles work to produce that heat as much, because basically that would also aggravate increasing intracranial pressure, if that makes sense. So you can control temperature without causing that shiver effect that will increase the intracranial pressure. Okay. And then you're checking for traumas and everything. So this occurs on a atomic clock. I want you to be aware of, again, as you see, I'm not tech savvy. I have to erase all of that. You need to be aware, since you are on the clock, that some nurse is making the time. So there's a time holder. It's like any rapid response or any code, you need to make sure there's someone holding the time. Be always aware as a resident or as a physician who's treating these patients, you have your rapid response, you have your code blue, you have your staff assist. Assuming a patient is seizing, they will call a staff assist who will call you in the room. This can be mainly implemented locally at my facility. However, it can be happening also in different, so you need to be aware of the difference of it. That will call you in, you will be there. Be aware that at 5 minutes you're anticipating that not to respond to your first or your second line of treatment that you're giving, that you need to call a rapid response. You need to call your RTs to be here. You need to call your experienced nurses that will always help you. You need to get more and more backup in the room, but control the crowd. You need to make sure you're controlling the crowd. You need to make sure that everyone in there is not causing more harm than good. You need to make sure that if you're bouncing or if you're talking out loud, you're getting beneficial feedback, and you have that closed loop communication. Okay? So, and then be aware that a seizure can be considered a code blue if a seizure is lasting more than 20 minutes. In some guidelines, it is considered a code blue. Remember, time is brain at this point. Okay, so these algorithms you can see all over the place. You can read multiple articles for it. You can do whatever you like. I like a visual person. There is CHOP algorithms, which is a structure algorithms. There are Seattle Children's algorithms, which are more of a visual colors algorithms, which I like. And you have Texas Children's. These are open source websites, which you can always log in and find those algorithms, find the one that suits you best and suits your personality the most, or the way you learn things. Okay, so now we are talking about patient is having seizures for 5 minutes. Okay, doctor, the patient is seizing. It's been 3 minutes. What do you want us to do? Be aware that this is a real life scenario. So if you are telling them, hey, prepare this medication, hey, do this, it's not gonna happen in its second. They need to draw it, At times, there's double nurse verification. There's lots of things you need to do. But you need to be aware that your first line is benzos. So I have this lorazepam. So you can always tell them, hey, give that patient lorazepam, or not give, draw or get. So they will get the lorazepam. You need to tell them, I want 0.1 milligrams per kilograms. Either memorize it or have an open source open. One of them helps usually. I like to memorize certain dosage because these are the ones they need to think on your feet, and at times they're not in your coding sheet. So status epilepticus is not in your code, at least in my facility, it's not in your coding sheet. So at times you need to memorize it or have it on you. So you're going to order lorazepam 0.1 milligrams per kilogram. Be aware of your max dose, which is 4 milligrams, and you're telling them to give that IV. Make sure they close loop with you and saying it back in milligrams, or however you mention it to them. I like to say my doses in milligrams because it will happen at times in real life events where they will close loop with you and tell you it's mLs. Different formulation, different presentations of the drugs. You need to be aware of what you have in your facility when you're mentioning it and the closed loop that you're saying. If you said give that patient 2 milligrams, she should be telling you I am giving, or he should be telling you I am giving 2 milligrams IV. Now, and you give it at 5 minutes mark, or earlier if there is any vital instabilities. But you give it at your 5 minute mark at this point, and let's say, oh, I don't have an IV access. What should I be doing? You don't fight for that IV as much. Someone will get, some more experienced nurse, some experienced physician will come and try to get the IV. Nor in status epilepticus, everything is spastic. As we all know, pediatrics by themselves are difficult to IV access at times. It just adds to it when it's status epilepticus. You need to know that you have your midazolam. You can use your midazolam. It differs, but you can use your midazolam. You can do 0.2, 0.3 milligrams per kg. You know, your max dose is 10 milligrams in general, and these can go intranasal. Okay, so when you're telling them prepare midazolam or Versed, whatever dose you're going to give in milligrams, you're going to give it intranasal. Make sure you're telling them this, and make sure you're giving it intranasal with a vaporizer. Why? Because at times when it happens, when you tell them this, I have seen it being squirted in the nose. And when it's squirted in the nose, it doesn't have that effect on the surface area where you get with the vaporizer to get absorbed in the nasal capillaries. And basically, it gets suctioned in the mouth or swallowed or aspirated, and the patient is not benefiting from it. Or you can always use your diazepam rectally, which is Valium. Or you can use intramuscular. But be aware if you're giving anything that you troubleshoot. Even when you give rectal diazepam, there's a tube that you have to give it with, and there's a different mechanism. So always be aware of how you're giving your modality. You're giving your medication, you're giving your dosage, you're double checking how the unit is given. You're giving it in this area, and you make sure it's given in the right way. Okay, so 5 minutes comes, you gave that patient. Okay. Oh, I can do that. You gave that patient, and I gave that patient at 5 minutes. The patient continues to seize. What can we do next? Basically, what you want to do next is give your second dose. So we said at 5 minutes. At 5 minutes. This is 10 minutes, and this is 15 minutes. This is 20 minutes. And then here at 30 minutes, okay? So you're giving it at 5 minutes. At this point, you gave whether you gave your Ativan or your lorazepam, you gave your midazolam. Patient continued to seize at 10 minutes. You can always repeat that dose again, the same max dose, if you're ever gonna give it, and you don't have to double the dose or do anything. You give the same dose that you were given, okay? At 15 minutes, patient is still seizing. You need to be aware that you have different modalities. Now you can jump to your second line. It depends whether this patient is less than 2 months of age or more than 2 months of age. If you remember, we mentioned that earlier, the 2 months or less than 2 months because of that neonatal seizure period and which one is better. But know that 2 months of age, less than 2 months of age, usually can benefit from phenobarbs. Okay, as your second line or third line. Phenobarbs, and you need to be aware when you're giving phenobarbs that you're giving 20 milligrams per kilograms. Aware that, and you're giving that IV, you're giving your maximum is 2 grams, and you're giving all of that over 10 minutes. I've seen people say push the medication as fast as you can. I've seen people say give it over 30 minutes, but be aware you are fighting time and fighting brain. So be aware of how length you can give it, because patient nurses will ask you, how do you want to give it, over how long, with what, okay? And with what makes a difference, because, for example, when we give other second lines, for example, when we give other second lines, like, for example, we use the Livrictam, which is Keppra, we give the 60 milligrams per kilograms with a max of 4.5 grams over 10 as your second line, and you jump to fosphenytoin. When you give fosphenytoin, remember that we don't use phenytoin anymore, especially in toxicology patients. It has not been proven to work as much. There are studies that shows using phenytoin, especially in patients with tox, will just make things worse, especially with arrhythmias and effect on the heart. When you give fosphenytoin, be aware if you're giving it with dextrose or not, because there's an interaction with dextrose. So be aware what's running and what are they diluting that with. Make sure if you're giving a valproic acid to be aware that these patients do not have inborn iron metabolism, less than 2 years of age. At times you don't want to give it. If it's a first-time seizures, unknown metabolic diseases, when you're giving a valproic acid, because at times it aggravates it, especially with its effect on carnitine. So that being said, what happens is now we know that the patient continues to seize at all of these points, and you're running through. When you reach the 20 minutes, you need to know that this is a code blue. Because of the straining effects on the heart, the straining effects on the brain, you need to be aware at this point that you need more help, you need more intervention, you need PICU escalation. You want to make sure that if need be, it's a complex medical history, that your neurologist on board and is recommending things that you can do and further intervention on the multiple drugs that you have. At times, we've seen status epilepticus can last for days, honestly, and you have to reach that point where you decide, when am I going to put these patients on pentobarb coma? And that's a different story for a different day. But what I wanted to make it clear for this as basics is that we are aware of giving, what are we looking for? We're doing our ABCDEs. We are doing our first line. We know when to call. Also, I've seen this happen, and you need to be aware that status epilepticus in itself is not an indication for intubation. You do not intubate a patient because they're in status epilepticus. As long as you can oxygenate them, as long as you can ventilate them, you do not have to intubate them. And usually you intubate them if there's a comorbidity, if there's a persistent post-ectal respiratory distress, regardless of the escalation of respiratory support modalities that you're using, and you give it enough time to think that there could be that drive more than the post-ectal state. But people at times jump for intubation, and as far as the literature goes, status epilepticus in itself is not an indication unless it overlaps with something else. Okay, just be aware. It's very stressful for everyone to be in a rapid response, but you have your knowledge, you have your information, you can have to control your team and be aware of the consequences of some actions, and when that you are in depth that you need to call help for. Afterwards, after the seizure is controlled, or you need to go through your labs, go through your imaging that we all discussed from before, which is basically, does that patient needs a CT brain without contrast to check for bleeds or hemorrhagic strokes or signs of an infection? Then you will need a contrast for that. Well, this patient needs further imagings later on the next day for MRI, or the same day based on their neurology recommendations, or you pick your recommendations. You want to check your labs, you want to see is there any signs of infection, but be aware that leukocytosis and neutrophilia can be there post-stress from an ictal state. So be aware of your bands. Looking for your CMP at this point, because you're looking for not just electrolytes, you're looking for renal causes, which I forgot to mention earlier, or hepatic causes, which I also forgot to mention earlier, which are important for hepatic encephalopathy. You want to make sure your ammonia, your LFTs are good. You want to look at your BUN and Chariot. You want to do it additionally look for your urine drug tests and your acetaminophen or ASA toxicities, or other drug tests that you can add to it. And then if there is any other further indication, if you are afraid or you notice that the patient might have any arrhythmias, make sure you go for your EKG. If you feel it's a different story and maybe there is a thrombi showering clots to the brain in a patient that is hypercoagulable or bacterial endocarditis, and you want to check for DVTs, or you want to check your echo for your heart. So this is more of, we're going to go on you and clinical basis if that patient seems like it's indicating or not for it. And then work up the patients for inborn errors of metabolism, if need be, if there's high susceptibility for it. And always be aware of how you're drawing your labs. For example, your ammonia needs to be a free-flowing sample, not prolonged tourniquet on ice until it reaches the lab. These are very important things for you to be aware of as you're ordering, as you're mentioning it to your nurse. So basically, this is more of a, again, basic knowledge of seizures, these epilepticus, things to keep an eye on, things to be aware of as you know your resources, know your algorithms, know your literature. And as I always say, if there's any mistakes or improvements or new guidelines or things that you saw that you think we can improve in the lecture, benefit, something that we misunderstood or I misunderstood myself, please mention it in your comments. Please email me. Please let me know. We can always go back and change it. This is the beauty of medicine. We always continuously learning from people. We can always be wrong. We can always be corrected. We always have that flexibility. I hope you guys benefited. This is mainly a reminder for myself and for anyone that is listening, and I hope I can benefit from your comments, and let me know if there's anything we can do. Thank you so much for listening.